Well, good afternoon, ladies and gentlemen, from a beautiful Cape Town. It's warm, there's no wind, and there's not a cloud in the sky. And more importantly, we have a beautiful star-studded bunch of people here this afternoon. Firstly, we have Professor Ismail Bhorat. He's a person that needs no introduction at all, and he's going to be speaking this afternoon on cerebral palsy and obstetric perspective. As Steve Jeffrey a minute ago was saying, this is something on everybody's minds. Anybody that's ever done any obstetrics and still does obstetrics, this will be uppermost in your mind. Now, the faculty is Professor Bhorat, and the chair people are Professor Stephen Jeffrey, and then Chris is our assistant, and then, of course, me. My name is Peter de Jong. I have put up a few references over there to start with, because we have a large number of people that are logged on over here. And if you wish, you can take your photographs of those four seminal references in the South African Medical Journal. And you can see them over there. I don't have to go through them. And they will be important and the anchor of Professor Ismail Bhorat's talk this afternoon. So, ladies and gentlemen, and a special thank you to all those that have come. This is season 7, episode 1. It's the very first talk of the 2026 season. So it's wonderful to have a person of the caliber of Professor Bhorat that's going to be presenting. And the topic then over there is cerebral palsy and obstetric perspective. Steve, would you like to say a few things? Hello, Steve.
Yeah,
hello.
Absolutely. It's wonderful to be back, and we've got a great turnout tonight. And I don't think we can start with a more relevant topic to obstetricians, and I said this is on the minds of everybody every day with their practice obstetrics. So we look forward to it, and thanks so much for joining us this morning.
Thank you.
Thank you. Okay, Chris, if you can get Professor Bhorat's slides shared up there.
Yeah, let me just share that. Okay. Let's go to the slideshow. Yeah, very good evening to everybody. Thank you, Peter and Stephen, for extending an invitation to me to speak here this evening. I know you've been trying to get me on this platform for some time. Our times just didn't converge, but here I am. So this evening, I'm going to speak about cerebral palsy. So cerebral palsy is probably one of those conditions that had the most impact on the practice of obstetrics worldwide, actually, but also here in South Africa. Massive impact. I think from the first case in about 2006, where the court found for the plaintiff and the amount was involved was about, I think, 30 million. The door opened for the legal profession. They looked at us as a golden goose. There was an influx of cases. They got brazen. They started taking cases on contingency because they were so confident that they're going to get a result. And all of this had massive, massive consequences. The first massive consequence it had was that our insurance premiums went through the roof. In 2015, 2016, with one of our largest insurers, we were asked to pay 120,000 Rand a month. Completely unaffordable. Obstetricians were closing their doors. And we were looking at extinction of obstetrics in the private sector. But we did fight back. There was an improvement, but we're not out of the woods yet. We're still paying too much for our subscriptions. Anything between 40 and 65,000. It all depends what insurer you are and what contract you have. So we need to have an impact on this. The second major impact it had, as Stephen said, it took the joy out of doing obstetrics. Every time you walked into labor room, you replaced joy with fear. You were terrified that if something went wrong, your next 5 years would be in ruin. Anxiety, stress, all of that. The third thing that happened was that our C-section rate went through the roof. We started practicing defensive obstetrics, and you cannot blame our colleagues because it's only you that when you get sued, you stand alone in the dock. We stood in the dock showed the one cheek and got bashed, and showed the other cheek and also got bashed. Because we never gave an obstetric perspective of cerebral palsy. All the discussion points were either pediatric, were neurological, or neuroradiological. And we were quiet. Around about 2019, myself and a group of fellow fetal specialists, we got together. And I like to say that we started a cerebral palsy project. We've published about 6 articles on cerebral palsy. And I would like to say that we've had a big impact on how cerebral palsy is viewed in court. We've given another perspective. Most of the papers that have been shown here are in case law. And speaking to a large insurer recently, they said that they haven't had a successful case of CP in the court for the last 2 years. So I hope that we had something to that.
Thank you very much indeed. Applause, Ismail. Applause, applause, applause.
Thank you, Peter. My talk today is going to focus on a few things. It's going to focus on scientific causation, because nobody is going to do scientific causation besides us. You don't want to expect a neurologist or a pediatrician to do that for us. We have to do it ourselves. So I'm going to look at scientific approaches to establish causality and legal clarity. I'm going to discuss something called priming. I don't know whether you've heard of it, but for me, that is the main factor in the genesis of cerebral palsy. I'm going to try and answer a very provocative question. Are fetuses predisposed to getting cerebral palsy? And there's some evidence that it is. And ladies and gentlemen, if that's the case, you and I'm sorry, we are hiding to nothing. Because no matter what we do, we're going to get CP cases and we're going to get blamed for it. And how does all of this influence us and inform us in terms of obstetrical strategies, in terms of how do we firstly protect ourselves and how do we prevent cerebral palsy? Now, when you go to court, the lawyers have a certain MO, modus operandi. They want to prove 4 things. They want to say it was intrapartum. They want to say there was intrapartum hypoxia. They want to say there was negligence. And they want to say it was preventable. And I'm going to punch big holes in all of those 4 notions with this talk today. Because cerebral palsy is a condition that is not always predictable due to variables not accounted for. And you know that from your own experience. You can do exactly the same thing in one patient and get one outcome, and do the same thing in another patient and get a different outcome. We now know that the roots of cerebral palsy are in the antenatal period, and that the intrapartum period is just a modulator. It's just a final step in an established pathological problem. And this is against what the perception is, that it's intrapartum. And the legal profession is obviously found a loophole with the RAF closed now. It's a portal to a multi-million rand industry that's fraught with corruption and vested interest. So in cerebral palsy, we have a perfect storm. We have a condition that's easily diagnosable in the postnatal period or even years down the line. You've got clinical, you've got radiological, but scientific causation is elusive because there's so many variables. And these gaps are exploited in court by the legal profession, with the help of our colleagues, who I would like to say some of them are serial experts and rogue experts. And they lend themselves to easy legal manipulation because all they have to do in a confrontational area in court is that they have I proved this beyond a reasonable doubt of 51% because they want to get their hands on those millions. The prevalence of CP in LMICs is about 2 to 10 per 1,000, could be higher because of the associated mortality. But in high-income countries, it's about 2 to 3 live births per 1,000 live births. Let's start here. Cerebral palsy is a tragic condition. It's a tragic condition. But it's also a complex condition. It's a non-progressive neurological disorder primarily affecting the way the child moves, speaks, movement skills, and unfortunately its IQ. And there are many types of CP. The commonest one is spastic in over 2/3. You have abnormal walking, abnormal reflexes, contractions, etc. But there are other types. There's dyskinetic type, hypotonic, ataxic. So if we encapsulate the problem of CP, It's the primary reason for high quantum litigation against obstetricians. The default reason for CP is always intrapartum hypoxia, evoking negligent intrapartum care. But here's it. Almost every epidemiological study from McLennan and everybody that you will read and you can research, we've researched this extensively. Every study tells us that only 10 to 15% of CP is related to intrapartum hypoxia. That's in high-income countries, and that will probably more or less correspond to how we practice here at private. In LMIC, it's about 30 to 35%. So if we look at this data, it tells you that statistically, I'm talking about now, that if you are getting sued for cerebral palsy, there's a good chance statistically that you are being falsely accused. Also, intrapartum hypoxia, even if there is intrapartum hypoxia, it does not always mean negligent care, because you can get sentinel events that can either be revealed or they can be concealed. And I'm going to go through that with you. That can be completely out of your control. How do we diagnose cerebral palsy? So you've got to have the clinical, the spastic, the dyskinetic, etc., etc. And you have got to have the radiological. So you might have heard these terms. The neuroradiologists talk always about this. You get the acute profound picture and you get the partial prolonged picture. Now, the acute profound is exactly what it is. It means it was an acute hypoxic episode. There was no time for arterial redistribution. So the gray nuclei, the vital structures of the brain got involved, the limbic brain. And it's often referred to as a BGT injury, basal ganglia thalamic lesion. The other type is partial prolonged. Partial prolonged means that it was chronic hypoxia. It happened over a period of time. So there was arterial redistribution and there was sparing of the gray nuclei. So what happened is that you've got border zone white matter lesions and you had sparing of the mammalian brain, neocortical lesions. And it is this type of CP on radiology that you will often get sued for. But it's not clear-cut. It's not as clear-cut as what I said, because many of these MRIs and things like that give you a mixed picture. So you must always differentiate between a radiological perspective and a causative perspective. Now, if ever you've been in court for the CP case, you will see that neuroradiologists come in there, very impressive. They come with PowerPoint slides, beautiful illustrations, fantastic, very impressive. The courts are totally impressed with that. And fine, good, right? So they're very good. They can correctly identify whether it's acute, profound, partial prolonged, blah, 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 whatever it is. But this is where I have a big issue with them, is that they come to court and leave the radiology and then tell the court, I think it happened intrapartum, 2 hours into the labor process. These MRIs are done 8 years, 7 years down the line. The insult, when the insult happened, there's a super wide variation. You cannot confer precision on it, and there's enough data to back that up. Often you got a mixed picture. Different etiologies give a similar picture. From the Helix trial now, we know that the partial prolonged picture is not always hypoxia. Infection can do the same thing. Infection can give you a partial prolonged picture. The stressful physiological process of labor itself on a primed hypoxic fetus may not be an acute event, but I will discuss all of that as we go along. How do we solve this? It's not easy to solve, isn't it? At the start, I'm going to tell you, SASOG has given submissions to South African Law Reform Commission. And we do not believe that med-mal cases and CP cases should be going through a normal court process. It's inefficient. It's run completely by the legal process, by the legal profession. We as experts come in and do a performance that is judged almost completely by the legal profession, and they make the final decision. It cannot be like that. And it's confrontational. We should have a mediation process or special medical tribunals. So this is the submissions we've made. Hopefully we will see them. We'll see them come true. We will have to wait and see for about that. But it doesn't matter on what platform you are giving evidence. It doesn't really matter. Establish proper scientific causality and lead robust evidence. That's the solution. You know, you'll be shocked that multi-million rand quantum cases are based on plaintive verbal accounts of the intrapartum process. and CTGs. Now, let me tell you something about the CTG. CTG has got a false positive rate of 50%. It's almost as good as a coin, for a toss of a coin. I'm talking about the type 2 CTG. And it can be retrospectively analyzed with full bias because you know what the outcome was. And you have a late MRI, which is extremely poor in timing. These are the modalities that the courts use to determine a 35 million rand quantum. Cannot be. In 2021, we produced clear criteria on how to implicate intrapartum hypoxia in CP, HIE. And it's come out that cord pH, and I'm going to discuss a lot about that, is a crucial component of this algorithm. But that's not the only factor. There are many other factors. I will go through that with you in this talk. We've produced an algorithm that's easy to follow in the courts. And again, I'm going to reiterate, the modus operandi of the courts is to say it's intrapartum, there's neglect and it's preventable, but I'm going to puncture holes in that, those notions. For me, one of the most important factor or factors that are involved in the genesis of cerebral palsy is fetal priming. So what is fetal priming? Fetal priming is an antenatal factor or a set of antenatal factors that act in synergy and prime the fetal brain for hypoxic ischemic injury. It creates a vulnerability and susceptibility to the hypoxic stresses of the intrapartum process. Remember, the intrapartum labor is a hypoxic-centric process. You're cutting off blood supply to the uterus and to the baby, but because the baby's got reserve, it's fine, doesn't have an issue. But it may be in a primed fetus, the final straw in a pathway to HIE or neonatal encephalopathy. I'm using it interchangeably now, but as the talk goes on, you will see that we should not use neonatal encephalopathy and HIE interchangeably. Priming could convert a minor hypoxic episode into a severe neurological injury because the prime fetus cannot compensate. And that's right, because you do get hypoxic episodes in labor. It's the very nature of labor. But they have reserve, great reserve, if they're unprimed. And it doesn't mean a thing to the fetus. They get over it. So what are some of the antenatal factors that we talk about fetal priming? Some are innocuous. Antenatal infections, antenatal inflammation. You don't even think much about it. But infections and inflammation produce cytokines. They produce leukotrienes. Interleukin-6, for example, that sits in the neurons and reduces the threshold of the neurons to hypoxia. Another very important condition is late onset growth restriction. Now, late onset growth restriction is a real problem because those babies are not necessarily small. They may just be tailoring off the growth. And if you do not do a middle cerebral artery PI or a cerebral placental ratio, you're not going to know whether that fetus is hypoxic. Diabetes, substance abuse, maternal factors, post-maturity, primary placental problems. I mean, now that we do a lot of placental histology, we are seeing things getting reported like maternal vascular hypoperfusion, fetal vascular hypoperfusion. Our technology can't even dream of detecting those things. Vascular issues, perinatal strokes, coagulopathies. And what has come to the fore from many studies now is that umbilical cord issues play a major role in the genesis of cerebral palsy. And what am I talking about? Things that we think are serious, but not that serious. A single umbilical artery, filamentous cord insertion, marginal cord insertions, hyper and hypocoiled cords, true knots. And lastly, the cherry on the top. Are fetuses predisposed to getting cerebral palsy? Do they have genetic polymorphisms that predispose them? Oh, we've tried to prevent HI and CP in the last 40 years. We've introduced intrapartum electronic fetal monitoring. We've got fetal ECGs. Our cesarean section rates have gone through the roof. But I've got news for you. Our attempts to prevent HI and CP, despite all of that, have been largely unsuccessful. The dial hasn't moved. Why? Because we are also stuck in the intrapartum period as obstetricians. We think it's only the intrapartum period that causes HI and CP. And the modalities we use for management is based on that. And that's why it doesn't work. Peter, you and I, and everybody else in this room, we have a partial pressure
Yeah.
of oxygen of 13.3, and our sets sit at 98%. Okay?
Right.
You okay with that?
Yep. Yep. Good.
If we're crazy enough to go climb Mount Everest, we will probably die because our partial pressure is going to drop from 13 to 3, and our sats is going to drop to 54%. In fact, if our sats drops to less than 90, they will probably roll us into ICU and put a throat down our throat. Look at the numbers of a term fetus. The partial pressure of oxygen in a term fetus is 2.5 to 3.5. It's almost equivalent to you standing 8,400 meters above sea level on Mount Everest. And the saturation of a fetus is 65%, which isn't great. But why are they fine? Look at the pH. The pH is normal. The pH of a fetus is almost the same as yours and mine. For the simple reason is that they have hemoglobin F, we have hemoglobin A. They can move their O2 dissociation curves, the oxygen dissociation curves, left and right as they need to, attracting and releasing. And they are fine. But it doesn't take a big step in your imagination to say that if these fetuses are primed for hypoxia, their path to neurological injury is to be very, very short. So even if you do a Caesar on a fetus that's in labor with fetal distress, but that fetus is primed and it's got an abnormal fetal heart rate, it might be that damage is already done. Hence, we're having difficulty in moving the dial for CP. So I've been talking about fetal priming for 6 years. This is a slide I got from ISPD 2 months ago, International Society of Prenatal Diagnosis, and they're saying now we need to talk about fetal reserve index or fetal priming index. That's crucially important because the way a fetus responds to an abnormal fetal heart rate pattern doesn't depend on the fetal heart rate pattern. It depends on its reserve. If its reserve is not good and you've got an abnormal fetal heart rate pattern, that would result in serious injury to the fetal brain. Look at the HELIX trial. Let me tell you something about the HELIX trial. This was published in the Lancet Global. Okay. This is the conclusion they reached. I don't know how it went through the reviewers, but anyway, this is the conclusion they reached. That all LMICs should immediately suspend cooling in neonates with HIE due to the reported absence of benefit and the increased mortality of neonates who were cooled. And you and I know that therapeutic hypothermia and cooling is one of the essential therapeutic maneuvers of HIE. How is it that this study, the HELIX trial, that was published in the Lancet, has come to this conclusion? And I must say, credit to a South African who rebutted this immediately. You said, oh, this is totally in contrast to the experience in South Africa, where therapeutic hypothermia is an essential component of treating HIE. So why was there such a huge difference between the HELIX trial and what the normal experience is? The difference is related to how intrahypoxia was defined. If you look at the HELIX trial, there was no report of neonatal blood gases. We didn't even know if they were hypoxic. There was no cord pH, so we didn't know whether they were hypoxic. But if you dig a bit deeper into the HELIX trial, you'll find that sepsis or infection, which is an important priming factor, limits the benefit of cooling. And we found that a substantial number of those neonates did have infections. And a lot of the people who reported back and rebutted it have said that white matter damage that was detected was not due to hypoxia, but it was due to infection. And it is the partial prolonged ones that you get sued for. So there are different etiologies that can give you the same story. And thus, the resistance to cooling. So the controversy of the HELIX trial has now added another dimension to the need to establish scientific causation. Not only do we need to identify markers for hypoxia for medical legal reasons, but it's also to identify which infants are going to benefit from immediate therapeutic hypothermia or won't. Because as we know, therapeutic hypothermia is essential in preventing further deterioration in HIE. Do you think that fetuses are predisposed for cerebral palsy? Okay, let's look at the data. This is the NESHI trial. The NESHI trial is performed right here in South Africa. That's neonatal encephalopathy with suspected HIE. They looked at a cohort of 172 neonates with suspected HIE using whole genome sequencing and variant association testing. And here it is. They found 71 fetuses with significant variants, 41%. Okay. So what were these variants? So these variants were around the PRKN set of genes that causes ubiquitination dysregulation. Now, what the hell am I talking about? So ubiquitin is a 76 amino acid protein that covalently binds onto substrates and puts the target on the back of that substrate, accelerating programmed cell death and apoptosis. So if you've got ubiquitination dysregulation, you will enhance apoptosis. And that's why you can, the neural injury is accelerated. And that's got nothing to do now with all the other stuff about, yes, hypoxia may be very mildly there, but it's completely accelerated in the presence of these genetic variants. And there's another thing, these subset of variants end up with severe HIE, even in the absence of the hypoxia. And they also have poor response to cooling because it's not really hypoxic related. It's related from a pathogenic mechanism that is run by the gene makeup of the baby. Andres Morena de Luca in JAMA in 2021, he published this paper. He showed exome sequencing of 2 cohorts of CP patients and showed a pathogenic causative variant in 33%. Wow, almost similar to what they picked up in the NESHI trial. He commented that a positive genetic diagnosis is the best CP defense against birth injury malpractice. And with time, as the tech improved in genetic diagnosis, we've improved in our diagnosis of intellectual disability or CP. A karyotype will give you only 5%, whereas if you increase the tech to CMAs and whole exome sequencing and whole genome sequencing, etc., your yield goes up to 50, 60%. So it's just a matter of bandwidth. And I can tell you in the next 5 years, more variants are going to come into play, and CP is going to become a genetic diagnosis. That's my prediction. This is a very, very important statement to make. Not all neonatal encephalopathy is secondary to HIE. There is this tendency that if you have neonatal encephalopathy, that's hypoxia. It's an easy way out. We need to understand the role of intrauterine environment in genetic syndromes. We need to understand the role of genetic variants in the diagnosis, the differential diagnosis of HIE, and the role of neonatal conditions, which masquerade as HIE in the diagnosis and differential diagnosis of HIE. Remember, we have a trifecta of factors. We have the intrauterine environment. We have the fetus with acquired problems, right? That's priming. And we have the fetus with its genetic makeup, that is genetic polymorphisms. And your labor, right? The outcome of your labor is not determined often by the labor itself. It's determined by these trifecta of things. So if you concentrate on the labor alone, looking at CTGs and late MRIs, and you don't look at this trifecta of factors, your conclusion, sorry to say, is going to be hocus pocus, because you have not involved the main criteria in the genesis of that intellectual damage or that CP. And there's a term called HIE mimetics. There's a term on near-term babies that have encephalopathy you see similar to HIE, but due to other causes. And often you'll find that maybe you didn't have all the markers for HIE, the APGAR wasn't that bad, but this baby's got neonatal encephalopathy. What the heck is going on? Throw the net wide. Infection is probably one of the big causes of an HIE mimetic. Brain malformations, vascular, neuromuscular, genetic conditions, inherited metabolic disorders, metabolic derangements, even maternal medications like SSRIs have now been implicated in neonatal encephalopathy. And then we come to multi-omics integration. Now, don't worry about that. But at the core of the multi-omics integration is the genetic core. Is there a PRKN variant? Because this causes acceleration of apoptosis. And you got, as I spoke about, the ubiquitination, dysregulation. Then you add your metabolomic data, proteomic transfer, all of that. Your signals are now showing you that these babies, right, are inherently having accelerated apoptosis with heightened neuronal injury after even a mild hypoxic incident. So I've given you a preamble, but we are not basic scientists. We are clinicians, right? We work in labor wards. So how does all this information that I've given you inform or impact us at the coalface? What should be our obstetrical approaches to this condition in terms of protection, self-preservation? Because as I told you, statistically, it's likely that if you ever get sued for CP, that you've been falsely accused statistically. And how do we prevent it? So obstetrics is not an exact science, we know that. There are many variables that correlate to give you the eventual outcome. Half of the roots are in the antenatal period. And here's the thing, you could have an hypoxic fetus entering labor and you know nothing about it. Or you could have had an antenatal hypoxic episode that already occurred, recovered. So when the mother comes into labor, the CTG is completely reactive. And now we know that up to 20% of CTGs, when the eventual diagnosis of cerebral palsy is made, are completely reactive. It's frightening, isn't it? If anything you want to take home from this talk today is this. Your main protection is doing a cord pH. For 250 Rand, whether the medical aid pays or doesn't, it will save you a lot of grief. It's a quantitative measure of the conduct of labor, and SASOG has given a blanket recommendation now that cord pH should be routinely used in all deliveries. Don't think because you had a normal delivery, everything looked fine, you're out of the woods. This child could get a postnatal cause of cerebral palsy. And believe you me, if the cerebral palsy, they're going to come back to you looking for problems intrapartum. We wrote this paper already in 2017 together with Low Posterior Priya Somapille and Ismail Smuts. And we made the case, even before the Cerebral Palsy Project, the case for routine use of umbilical cord pH in all deliveries. And the statement from Wong et al. In a major study on cord pH said, a normal pH, in effect, excludes a causal relationship between acute intrapartum hypoxia and subsequent neurological development. And don't worry about false positive. The false positive rate is 2%. It doesn't even impact. But if you do a cord pH, you're gonna get two results. It's either normal or abnormal. If it is normal, I'm going to go so far as say you're off the hook. There is no way that anyone can pin an intrapartum problem on you if that cord pH is normal. No ways. If it is abnormal, then there was hypoxia. It's also important that you would start with therapeutic cooling immediately. But also we would now have an opportunity to investigate this, to see if there was intrapartum neglect. Because as I said, not all intrapartum hypoxia is due to neglect. So this is the paper we published in 2021, looking at criteria to implicate intrapartum hypoxia. And this should be in your back pocket in labor room, because this is going to get you off the hook. Because if you end up with a spastic or a dyskinetic CP with neonatal encephalopathy, they're going to come to you and they're going to try and blame you for this. If you've done a cord pH and your cord pH is greater than 7.15 or better than 7.2, you're off the hook. If you've got an APGAR of greater than 7, it's good for you. If it's less than 5, it's bad for you. But APGARs are subjective, they're falsified, and the courts don't look at it in a very good way, believe you me. An early MRI is pretty good in working out when the insult happened. But very, very few neonates get an early MRI, believe you me. Is there multisystemic organ failure? So if you've got hypoxia in the brain, it's very, very likely that you have hypoxia somewhere else. It wouldn't be sort of isolated. So it's a factor that either is for HRE or against HRE. Was there a sentinel event? Now, not all sentinel events are wow, like an abruption or a cord prolapse or maternal vascular collapse. Not all of them are like that. You get even concealed sentinel events, cord compression, abnormal, as I'm saying, umbilical cord abnormalities is a big factor now in the genesis of CP. The CTG, I'm going to discuss a little bit about the CTG, but at the moment, the type 2 CTG is unhelpful, okay? Because it's got a false positive rate of 50%. It's a coin toss. A late MRI, normally done 7, 8, 9 years after the event, is pretty good in delineating the brain injury, but it's poor in timing. Priming. All proximal and distal factors that cause CP must be included. And in 2026, I'm going to add another 2. One is there genetic polymorphism? And 2, do we have placental histology? If you follow these criteria and have enough information with every delivery that you see, no one is going to come to you. And we can go to the insurers and ask them, why are we still paying 65,000 Rand a month if there's no cases of CP? So your protection is you have a holistic approach. Your antenatal period and intrapartum period are sequential, intertwined, and interwoven. Okay. Work out all priming factors. At the end of your antenatal care, you should have a big sticker, priming, high risk, low risk, intermediate risk. Do a cord pH for every delivery. And in certain cases, I can't do histology on everybody. In certain cases, histology. How do you prevent CP? To prevent CP, we have to have a mindset change. Even you and I, forget about everybody else. A lot of us still believe that this is an intrapartum problem. We have to get away from that. It's not an intrapartum problem. Your antenatal history, and it depends how intense your antenatal history is and how much you've done, because that becomes the prime determinant of the mode, timing, and technique of your delivery. Because the intrapartum period is not an isolated period. Maybe it's our fault. We kind of compartmentalized it, but there are absolute links between the two. And as I said, record all possible antenatal factors that could predispose to neurological damage and clinical risk for fetal priming. You know, this is a slide I got off from the last Fetal Medicine Foundation in Prague. I found this a fascinating slide. So they introduced a 3rd trimester scan at 36, 37 weeks in the UK. And they looked at the data prior to 2013 and after 2013. And they found that when they introduced the 3rd trimester scan, they got an 80% reduction in stillbirths. An extrapolation would be that if they didn't have stillbirths, these babies may have had CP. So what do you do at a 36 or 37-week scan? Two simple things. You look at fetal reserve, and what is looking at fetal reserve? You look at the fetal growth, not only fetal weight, look at the fetal growth trajectory for the last few weeks. Look at the amniotic fluid, look at the placental grade, and do a CPR. A CPR is not difficult to do. It's a middle cerebral artery, PI, divided by the umbilical artery. PI, and rule of thumb, it should be greater than 1. You don't even have to go to a graph and all of that. But I accept that not all mums are going to come in the late 3rd trimester. Maybe you've seen somebody at 33, 34 weeks, and the next time you're going to see that patient is in labor ward. But there's a thing called intrapartum ultrasound. It's called point of care ultrasound. It's all the rage now. You can do simple things like fetal weight, AFIs, placental grade. The weight itself may not be that important, but you can compare it to what you had 4 or 5 weeks ago. It's not always easy to do a UAPI and MCAPI, I accept that, right? Because it's a laboring mother. But you should try. If you can't and you really need it, get someone who can do it. If you're doing an induction, your indications should be solid. Do not enter the intrapartum period in a blindfold. It's not an isolated entity, but a continuum. And this is very important. Interpret the intrapartum data, your partogram, your CTG, and all of that in the context of your antenatal data and determine your threshold for intervention. And you would have done that already, because at the end of your antenatal care, you would have said, what the priming factor is. If you're using instrumental delivery, please make sure you've sorted out all the criteria, because the legal profession, as soon as you have an instrument delivery, they just focus on that. Let's talk a little about CTG. Look, the CTG has been with us for 40 years, not going anywhere. Maybe it's not the CTG that's the problem. It's maybe the way we interpret the CTG that's the problem. So a lot of units now are going away from the standard 3-tier system of interpretation to a more scientific classification, linking fetal heart rate patterns to neurological injury and etiology. So this is what we all use, right? The NICE or NICHD, the type 1, type 2, type 3. Type 3 is useless. If you've got a type 3 CTG, that baby is already brain damaged. That's not going to help you. Type 1 is probably the most useful because it tells you everything looks okay. But remember that in 15 to 20% of CP babies, you're going to get a normal trace. The type 2 is the problem, 80%. But look at, even on the NICE guidelines, see what it says there. It is not predictive of an abnormal fetal acid-base balance. In other words, it's not predictive of hypoxia. So the PLN and intrapartum classification is what people are using now. And there's 6 categories. On admission, if you have bradycardia, that's the 1 category. On admission, if you have a non-reassuring trace with your STVs less than 5 beats per minute. 3rd category is RPD. The baby comes in with the fetus comes in with a good trace, and then suddenly within minutes, you're getting a prolonged deceleration, less than 80 beats per minute. Those are normally a sentinel event. It's probably unpreventable. The 4th category is called the R-horn pattern. This is when the baby comes into labor, very reactive trace, everything okay, and there's chronic hypoxia or subacute hypoxia, where there's the current decelerations, and over a period of time, there's tachycardia, bradycardia, and worsening. So it's the R-horn pattern that is subacute, and the RPD that's acute. And then, of course, you have the reactive traces. And if we can annotate that, you can see if you've got brain injury and you've got a bradycardia admission, the brain injury occurred hours before the admission. If it's a non-reactive trace, days before the admission. If you have an RPD where you get a reactive trace, but suddenly a dip, it's probably a sentinel event, either concealed or revealed. If it's an R-horn pattern, it's probably occurring over a period of an hour, so it's chronic. And if you've got a reactive trace, either the baby has had the injury and recovered, or the injury hasn't occurred yet. It's still going to happen postnatally. So there are 2 seminal papers on cerebral palsy looking at in excess of 900 CP cases by Nekau. This one was published in AJOG. And this is a really telling sort of paper. He said that hypoxic events in labor occurred for about 30% of cases. We think it's a bit less in HICs. That half occurred during the antenatal period. And the R-horn pattern, and this is the shocker. The R-horn pattern, which is the only type of CTG that is preventing cerebral palsy, only constituted 16% of the CTGs. Shocking. The reactive trace, as I said, either antenatally or postnatally, priming factors, and umbilical cord problems, according to Nekau, constituted 40% of all the CP cases. That was the only clinical issue. SUA, hypocoiled cords, true knots, velamentous cords, Wharton's jelly deficiency, true knots, all of those things. And he took those traces and he linked it to MRIs. So it is a very scientific way of doing it. And as I explained to you, acute, profound, partial, prolonged, mixed vascular lesions. And this is what he found. On the Y, it's got all the categories of the Pellan and N classification, the Brady, the non-reactive, the RPD, the RR. And on the x-axis, he's got all the clinical issues. The bar graphs, the red bar graphs are the BGT injuries, the acute profound ones, and the blue ones is your partial prolonged. But you can see that umbilical cord, the clinical issue of umbilical cord abnormalities was the common factor in almost all the BGT injuries, followed by placental abruption and your priming factors. And if we can make it easier and turn it around, what he found in terms of perinatal risk factors for BGT injuries in fetuses is that umbilical cord anomalies constitute 40% of BGT and about close to 39% for the partial prolonged types, for the chronic hypoxia. Abruptio, 23% and 4.5%. Intrauterine infection, 18% of BGT and 14% of the watershed. SGA, 12 and 25. Sentinel events, 10 and 2. No risk factors, 20%. They may have got genetic polymorphisms. So if we turn this around, in the Cow's paper that he actually published, he found bradycardia constituted in all this. This is looking at severe CP now, 11% of his cases, antenatal. The non-reactive trace that constituted CP was 25%, antenatal. The reactive trace constituted 18% of CP cases, either antenatal or postnatal. The RPD was 20%. That's intrapartum less than an hour. Sentinel event. R-HON, 16% intrapartum greater than an hour, unclassified 80.5. Numbers 1, 2, 3, and 4 are unpreventable. The only preventable CTG for cerebral palsy was the R-HON pattern, and that constituted only 16% of cases. So I go back. What's the modus operandi of the legal profession? Is it intrapartum? Wrong. Scientifically shown. Is it preventable? In a minority, 16%. It's mostly unpreventable. Is there negligence? Unlikely, because there's so many factors that coalesce to give you this. That statistically, although this is a tragic condition, it's difficult to apportion blame to anyone. If I come to perinatal sentinel events, they can be concealed or revealed, as I said. Half are concealed. You don't even know. They could be just prolonged bradycardia. They could be an umbilical cord issue, whatever. And only in a third are they revealed, where you can actually see like an abruption or a cord prolapse or whatever. All that I've said isn't a secret. It's all out there. And defense attorneys and colleagues who have had the unfortunate sort of position to get sued or whatever, this is data that's all out there. We actually even published a position statement in 2023. You can take this down, in addition to all the other papers that we've written, where we spoke about causation of BGT injuries in the context of cerebral palsy litigation. It's a SASOG endorsed position statement. So it's all out there. In conclusion, there are a few things I need to say. That for me, we need to get away from that whole intrapartum story. Even us, we need to get away from that. Intrapartum is important, but it's not, cannot stand on its own. It is informed by what happened before the patient went into labor. And fetal priming is the most important factor in the genesis of CP. So identify clinical risk factors before the intrapartum period. We now know, and it's going to get more and more and more as time goes on, that the genetic makeup of a fetus is probably one of the most important factors, the predisposition for cerebral palsy. At this moment, we have got variants around the PRKN genes, but many more will come to the fore. The antepartum, intrapartum factors are sequential and interwoven. We need to move away now from the 3-tier system, because the type 2 trace, which is basically 80%, doesn't help you. It's not predictive. We need to use the new 6-category CTG classification. It's shocking that only 16% of the CTGs that you're going to pick up using the Pellin and classification is going to result in a preventable CP. Please do a cord PH. It will save you a lot of grief, time, anxiety, and stress. And do placental histology in selected cases. For me, in every CP case that's brought to court, I want 5 essential components. I'm often an advisor to an expert. I want to know what the cord pH is. I'm now going to insist on a genetic analysis for that infant. I want to see if there are variants in the PRKN group, and as others come in more and more. I want to know all possible priming factors, and that is going to be dependent on your notes, on how good you document it, on all the priming factors that I've listed. In your back pocket, you've got the criteria that set out how do we implicate intrapartum hypoxia, and tick as many as you can. And where done, placental histology should be available. So this is what I'm going to ask for. And maybe on one or two of them, I will just say, but there is no case against you. And as I said, statistically, you are probably being falsely accused. I'm going to say something philosophical now. I started off by saying that cerebral palsy is a tragic, tragic, tragic condition. And unfortunately, all the data we have, and I have really up-to-date data, that it is very, very difficult to apportion blame. It's very difficult because our technology is just not up there to be able to diagnose all the variables that is going to eventually give a cerebral palsy. I cannot do a genetic analysis before the baby is born to know whether there's a predisposition. So it's very unfair to blame this at the door of an obstetrician. And that has caused us so much of grief, where we're subjected to litigation abuse for the last 20 years. But I think every CP child, irrespective of blame, irrespective of negligence, irrespective of no blame, no negligence, should be held. And the discussion should be around a global fund for CP. It makes no sense where scientific causation is telling us you can't really apportion blame to anybody, and you're paying one family 20 million and the other one gets nothing. That's just not fair. We need to have an earnest, serious discussion on how to fund a global CP fund with various stakeholders and role players. So I've been invited to the first Global Cerebral Palsy Prevention Summit that's going to be held in Bangkok in Thailand on the 11th to 13th of September 2026. So I'm very much looking forward to it. I'm going to give them the perspective from South Africa and obviously get perspective from elsewhere. And this Cerebral Palsy Alliance, I'm hoping, would have an impact on cerebral palsy in the whole world, which is the condition that has had the most impact on the practice of obstetrics worldwide. Thank you very much. Thank you, Peter. Thank you, Stephen.
Well, Ismail, it's wonderful talk, and it's given us huge food for thought. And your take-home messages are extremely important. We do have some questions. If I may start the ball rolling. The first question is, I have one over here. It says, in terms of computerized CTG analysis, for example, the stand machines, has there been any improvement in the possibility of identification of CP using computerized AI in CPD analysis, please?
So computerized CTGs, it came to the fore in the Truffle trial. I don't know if you know about the Truffle trial. The Truffle trial was where they were the preterms that were having, the DVs were abnormal, and they had high blood pressures and severe growth restriction. And they found that the computerized CTG really worked well in that. In terms of term fetuses, the computerized CTG, I think the jury is out there in terms of whether it really helps. Because I come back to my point, right? The computerized CTG is going to tell you something in case in point. It doesn't tell you on whether the baby has pre-existing hypoxia or not. It doesn't tell you whether it has a genetic predisposition to cerebral palsy or not. Those things are done from a holistic view of what is going on. So we don't even have computerized CTGs, and so we've tried to introduce it in many of the units, but we don't even have it. But the place for cerebral computerized CTG seemed to have been more in the Truffle trial with the severe IUGRs, whether to deliver them, not to deliver them, wait on and go on. That is where computerized CTGs actually really work. And computerized CTGs do not really play a real massive role in intrapartum assessment. They play a role in antepartum assessment, like in the IUGRs and things like that. So it's not going to help you intrapartum. And even if we reach a point where we're going to use AI and we're going to use, computerized CTGs intrapartum, we are still doing the same thing. We are not expanding our view on what are the real causes of cerebral palsy. So I'm not really optimistic about that.
Okay, thank you, Ismail. We've got a lot of questions. We're just going to have to whip through them very quickly. Thanks for a great eye-opener. Which cord blood vessel should be used, arterial, venous, or both? And is there any time factor for collecting these bloods? Should we routinely send placenta if we stow in babies who come out flat, or is the cord blood adequate alone? If you can give us a 1 minute answer.
Yes. So you should the gold standard is to do it in both, in the artery and in the vein. But if you don't have the time or you can't access the vein, the artery is what you need to get it from. So you need to take it from the umbilical artery, right? But the gold standard is to do it in both. You've got 30 minutes, right? So the pH of the neonate stays pretty stable for about 25 to 30 minutes. It's better to do it immediately, obviously. But if you've waited 15 to 20 minutes, don't discard it. It's still relevant. So you can do that. Okay. The other question was?
About the placenta for histology.
Yeah, the placenta. Look, I don't think we have enough histopathologists to actually do detailed, placental histology on every single case. So at the moment, probably not. But I would certainly do it where signs don't fit or the baby comes out flat and everything was looking well before that. Maybe there's maternal hypoperfusion or fetal hypoperfusion or whatever things must be going on. So I would do it in selected cases. But in your mind, for every delivery, a cord pH should be there or placental histology. So those two things should always be in your mind. Whether you do the placental histology or not, I wouldn't advocate it routinely at this moment in time. But cord pH definitely for everybody.
Okay, next question. What avoidable placental causes of CP can be proven on placental histology other than acute chorioamnionitis or funusitis?
Cool. Unfortunately, primary placental disorders, our technology doesn't help us. Our umbilical cords, ductus, and all of that do not tell us about what is going on. And that's what I said in the talk, that when you get placental hypoperfusion and fetal vascular hypoperfusion, our tech does not really detect that. And we'd only see it once the baby is born. So unfortunately not.
Okay, Ali Marudu says, you mentioned intrapartum ultrasound point of care. Should everybody get it? And what is the most important role for that?
So intrapartum ultrasound is only for those patients that missed their late third trimester scan, who means you've seen the patient 5 weeks earlier or whatever. But if you see the patient a week beforehand, or maybe a few days beforehand, there's no need for a point of care ultrasound. But what I'm saying is that if you last saw a patient at 34 weeks, and now she's 39 weeks and she's come in, you have no idea what happened in the last 5 weeks. In that case, a POC ultrasound is absolutely indicated.
Okay. There's another quick one. Yeah, some patients insist on keeping their placentas, defeats the purpose of histology. What we do is if a woman wants her placenta, she can have it after she's had the histology. That's not an issue. And then Trifina Kelly says, if you missed to do the cord blood, can blood be taken from the fetus, like umbilical vein or radial artery? Can you go needle the baby?
No, if you pass 30 minutes, you're not going to get a correct answer, unfortunately. You have to do it within 30 minutes.
Okay. I think that's all we have time, unfortunately. I'm going to ask Steve. All right, Steve?
Yeah, thanks. It's just Mzi, where to...
Stevie?
Hi. I can hear you guys. Mzi, where to... Hi, Prof.
And then, hi, Prof. Is that a question? I don't see a question there. Hi, Prof.
Well, just saying medical aids like GEMS are forcing patients to have an NVD. Is there any comment on that?
Ismail?
Yeah. This topic will need another 2 hours, isn't it, to discuss this. I always say that every mode of delivery has an indication. There's no such thing as an NVD is better than a Caesar or Caesar better than NVD. There are indications for each and every one. But if you followed what I said today, if you look at your antenatal clinical risk factors, and if you think that the clinical risk factor is high from a priming perspective, that patient should not have a normal delivery. I'm sorry. But we need to actually say that.
Well, maybe we can have a seminar in SASOG in August in Cape Town. So I always think that's a wonderful idea. Steve, we really are out of time. I'm going to ask you to thank Professor Ismail Bhorat.
Yeah, Ismail, thanks so much. It was wonderful. I think, every person on here has been exposed to stress related to a flat baby, as we've been speaking about tonight. And you've really given us an armamentarium. You've given us a strategy. We've been quite disheartened over the last sort of 20 years, as you've highlighted. But at least now we see some light at the end of the tunnel. And hopefully the pendulum swings right back to where we have cheaper insurances. The lawyers get off our backs. They also see that this is a futile attempt to extract money from us, and obviously have another strategy to fund the upbringing of these poor little kids. So we hope that you guys make progress on that. But keep it up. I think you're doing great work on this, and it's very inspiring to have heard where we are on this. We really look forward to hearing an update soon. So thanks so much. Thanks again to Pete and obviously Chris as well. And we'll see you all again next week. We don't know what we're doing next week, but we do have one next week, Pete.
Yeah. Thanks so much. And good night, everybody.
Safe home. Thanks, Stephen.
And thank you very much, Ismail. Safe home. And see you all, if not next week, certainly at SASOG in August this year, 2026. Thank you.
Thank you. See you soon. Bye.
Bye.